Claudia. So if you want to go to the next slide there. This is the webinar this afternoon. We're going to be talking about coronavirus and can artificial intelligence make a difference? And we're really talking about flattening the curve today with the COVID-19. Next slide. And I just want to, again, say thank you to everybody for joining us today. We have a really stellar, very impressive group of folks joining us this afternoon. John Fraunfelter, or Dr. Fraunfelter, who's the Chief Medical Information Officer with Javion. Priyanka Suryo, who's the Director of Informatics with ASTO. Lori Tremmel Freeman, who is the Chief Executive Officer with NACCHO. And John Showalter, Dr. Showalter, who is the Chief Product Officer with Javion. And again, I just want to say that you can go to the next slide so everybody can see what a great-looking group of people this is as well, Claudia. We are not doing this live video conference, but you can see we've got a really impressive group today. And again, I just want to, express our heartfelt thanks and our thoughts for everybody who's out there right now in healthcare provider settings, patient settings, everybody who's working in public health right now who's really trying to address this crisis. We're thinking of you, for those of you who have family or friends or colleagues who are ill. We know this is a difficult time, and I think this is a time when everybody in healthcare really comes together to try to address these tough issues. And we at eHealth Initiative are trying to pull together our resources and bring folks to you who are right in the middle of this right now so that they can share some of what they're doing and their knowledge with the rest of the industry out there. Next slide. Housekeeping items. So everyone is muted right now. There is a way to ask questions, though, if you would like. At the bottom of your screen, you'll see there's a Q&A box with a big Q on it. If you put your mouse down there, you'll see that pop up. And there's also a box that says chat. If you'd like to ask a question, you need to go to that Q&A box and type in there your actual question about content question about whatever the topic is you're interested in. The chat box is to be used if you have a technical issue right now or having a problem there, so use that. We're already getting questions about the presentation slides, and those are available on the EHI website, and there is a link there as well for you. Next slide. Oh, great. And Ali has sent out a link to the PowerPoint slide through the chat box as well. Thank you, Ali, on our team. So a little bit about eHealth Initiative and the Foundation. We are a pretty diverse group made up of leaders and executives across the spectrum of healthcare. This is just a sampling of some of the folks who are involved with our leadership with eHealth Initiative. And it's really a great group to be engaged with. Next slide. Our mission really is to convene all of the industry leaders and stakeholders, and you can tell by that list we do that pretty effectively, trying to figure out what are some best practices around healthcare that use technology and innovation to really help transform healthcare. And right now is a great moment to really tap into those executives and leaders in technology and innovation to figure out what are some great best practices and ways to address the crisis right now. Next slide. So normally we're focused on, these four areas: value-based care, interoperability, privacy and security, and analytics. And we have a whole host of topics that we are normally convening around and meeting on. Next slide. But right now, given the current crisis, we have devoted most of our research, education, advocacy efforts around the COVID-19 epidemic. And this is just a listing of some of the upcoming webinars and forums that we'll be hosting around that. We have another one coming up next week on remote monitoring, a couple on telehealth, billing for telehealth, and we have a whole series that we're doing, some virtual luncheons with federal leaders where you can ask questions about the new CARES Act and the policy that's coming out right now. So stay posted on that. And then before I turn it over, I just want to again say thank you to all the folks on the call today, and those of you who could not be with us, we're thinking of you and appreciate your efforts. So let me turn it over now to Dr. Fraunfelter, who's going to take us through this incredible panel.
Thank you, Jennifer, and thank you everyone for your time this afternoon in the midst of everything going on. You can go to the next slide. Really, the question in front of us is AI ready to help in healthcare, and particularly right now? If AI is powerful and it's in use today, can it pivot quick enough to address something like COVID, which came up pretty quick in the US? So just a bit about Javion. We're a company that leverages AI, and we're passionate about preventing harm. So our AI is pointed towards patients and patient outcomes that we're trying to prevent, and particularly harm. So we've been around for close to 10 years. We've demonstrated success with in multiple settings, both inpatient and ambulatory, with dozens of customers and more than 50 different use cases. We deliver precise insights into patients that give us awareness to those patients that we weren't aware of before who are at risk. These insights are actionable and they're powered by AI. And those three things together allow the providers to care for their patients differently and deliver superior outcomes at lower cost. So most importantly in that journey is we've learned a lot. We've learned what works and what doesn't work. And we've learned that the combination of socioeconomic determinants, which is now a buzzword, but we've been using it during the course of our existence. The combination of that with clinical data is very powerful when AI is applied to it. Okay. We are pivoting to COVID as quickly as everyone else because this is the situation on the ground today. This is a projection curve that was done, some modeling was done a few weeks ago by an imperial commission out of Great Britain. If nothing was done to change the curve, the US curve in the blue looks reassuring at first until we realize that 15 people per 100,000 population translates to 50,000 deaths per day at the peak if the curve is not flat. And this is just epidemiological math of a pandemic. We also see that flattening the curve can do some good and impact outcomes and impact that concept of saturation, patient surge, etc. And it's reassuring until you see that red line is the ICU bed capacity in the US. And so there's a tremendous amount being done to address this, okay? Just a little bit more around the current state in healthcare, which we're all familiar with, but this is the context. And to give an illustration, one state's modeling shows that saturation line, that dark line there, will be hit within the next week. And this is not just true of one state. There's probably half a dozen states where they're hitting their saturation in areas right now. I live in Michigan, and the Detroit market is hitting that point actually. And this illustrates that you can change that, but it takes a fair amount of effort. So the hospitals, and I'll focus on the provider section here at the top, they're anticipating this surge to come very quickly. And in the combination of an increased demand, they're also going to be dealing with staffing shortages due to providers on the front lines contracting the virus, along with shortages of supplies. And ultimately the challenges around how do I manage patients that need ventilatory support and we don't have enough ventilators. So these are the challenging questions and the trying time that we're in. And we need as many resources from different places as we can to help. And this is where AI can play a role. Okay. So what Javion is doing in this space, we're doing several things all at once. First is we're providing community level insights, and these are through an interactive map that's on a website. It's publicly available, and this allows people to see at the neighborhood level, at the regional level, the neighborhoods that are frail or fragile, we'll say vulnerable, because of the baseline socioeconomic risks. And that matters because the socioeconomic drivers are very important for ultimate outcomes. So this is it's not an epidemiological map. It's not a disease tracking map. It's socially vulnerable neighborhoods and things that can be done to preempt their increased risk of morbidity and mortality. The second thing we're doing with our health system customers, because we already have their patient data, is we're providing right now patient lists that are patients who are the highest risk if they were to contract the disease. And the aggressive intervention on those patients, both managing their comorbidities more aggressively and practicing self-isolation, frequent contact so they don't become more isolated and risk associated with that occurs. Those are the things that our customers are doing in response to getting this list and taking action. The third area that we're looking at and working on right now is identifying patients as they come in the emergency department and during the hospital stay, who is at highest risk and who's at lowest risk for mortality when they come in, so that they can be placed in the right setting of care. They can be treated more aggressively or perhaps even managed at home because their risk is lower than they might look just based upon clinical criteria. So that's some of the work that Javion is doing in that space. Okay. I'll turn it over to Priyanka now, and we will hear how states are engaging and using the technologies available to them. And Priyanka, I'm not hearing you. I'm not sure.
Priyanka's controlling the screen. Priyanka, is everything okay? We can't hear you.
Hi. Yes. Hello. So I gave back control because I wasn't able to unmute myself when I did that. So I'll request control now. Hello, everyone. Priyanka Suryo, Director of Data Analytics and Public Health Informatics at ASTHO. We are an association of state and territorial health officials. And so we essentially provide capacity and support to all of our state and territorial health agencies and their leadership to protect and promote the public's health. And you can see that on our vision and mission slides. And so we'll kind of continue moving forward. It looks like I should be able to do that. But if not, I know that someone in the back end can do that for us. So essentially, as I mentioned and as I gave in my introductory remarks, I lead our data analytics and public health informatics team. And as COVID-19 really started escalating and taking off in the US with the first case in Washington, we were pulled into ASTHO's incident command structure. So essentially, it is a structure that is prepared to support response efforts during pandemics or natural disasters. And we were pulled in to lead our COVID-19 data management and surveillance response efforts, specifically given our expertise and the fact that we handle these types of things on the daily within our current project work. And as part of those efforts, you can kind of see these 6 buckets here in terms of how we're supporting, although, you know, some of this is definitely growing and or changing as COVID-19 also evolves and changes for all of us. But we're doing routine policy surveillance, and I'll be able to show you a little bit more about that when I demo our map. We are mapping key data points, as I had just alluded to, in our States and Territories in Action COVID-19 response map. We are supporting a national data sharing effort, which I'll talk more about in a little bit, through our COVID-19 Syndromic Surveillance Collaborative Project with CDC. We are engaging with external partners to scope out new tools and technologies and to really get a better sense of what is being built, as well as how public health can better inform these different entities, organizations, companies that are building the tools to ensure that they are well suited to respond to public health's needs. And so some of that is by participating in hackathons, serving as a subject matter expert, providing direct input and feedback as products are developed. And then we're providing internal data management within ASTHO through an information resource tool. This is so that we can get a handle on all of the massive amounts of information that's been generated thus since, and to be able to get a better sense of what we have developed as a response to that. And then last but not least, offering technical assistance. And so I think we'll definitely get more into this during the discussion section, but we definitely would like to connect with our healthcare partners, with the health IT industry, to determine where our efforts do overlap and how we can improve some of that communication, what public health can provide to you all as guidance in developing your products and tools. And so as you'll see on the next slide, This really shows you a little bit more detail into that Syndromic Surveillance Collaborative project. And essentially, the big picture here is that shows where state health officials are really taking the lead on this national data sharing effort with CDC during this pandemic. And it's allowing for timely, consistent, and quality sharing of data. Specifically, the data that's being shared is ED visit, or emergency department visit data, de-identified, which helps to improve syndrome definitions or definitions for COVID-19 to be more specific, and establishes more and improved methods for tracking COVID-19 related ED visits or those that are symptomatic. There's also no additional burden for jurisdictions to participate in this. From what I've heard, it really takes a matter of minutes and just leadership buy-in and really their leadership to say, yes, we are going to share, we're going to be part of this national effort. And it follows an agreement that was put in place when the National Syndromic Surveillance Program was established. So again, there is something in the back end to really ensure everyone feels comfortable with the data sharing, accessing, and use, and also credits health agencies appropriately and ensures that there is the back and forth communication needed to ensure that they are okay with what is being shared or displayed. So what's really key to note about this that I want to highlight is that this effort is not a new one. CDC definitely tried to do this level of national data sharing with the Valley, which was the lung injury due to vaping. And they were able to get 12 states over a matter of several months. So it was really difficult. It was often delayed because states had to determine who could make that decision, what their data sharing capabilities were. They often didn't have that leadership buy-in. And so you can see on the next map, I'll show you, that we've been able to get 36 states to share within a month, which is quite phenomenal and really shows the power of this national data sharing effort. And again, it really relies on the systems being set up within those state health agency departments, and there being that communication and that trust to share that data with CDC and being part of the analytics on the back end. To the point of AI, I think having good data and having access to good data sources helps to fuel the algorithms that allow artificial intelligence to do the job that it needs to do to make those predictions. So on the next slide, we'll actually see more related to the map. And I believe I should be able to click the live demo. And so if I'm not, if it doesn't pull up, just let me know. But I have clicked it at this point, and it should have pulled up a screen or a web page on Claudia's side. So Claudia, you might want to exit out of the presentation and see if there's a web page there.
We can see the map, Priyanka.
Okay, great. I'm not able to see the map on my end.
Yeah, Claudia, I think you need to share the other window.
Yep, I think you might need to share the other window.
Yeah.
And I'm seeing panelists are not able to see the map yet, but don't worry, we will share that map. It's actually been updated since then. It was modified yesterday, so we've been updating it pretty regularly at this point. And again, I'll kind of walk folks through the map, and that'll be kind of the conclusion of our presentation. But it really shows how we've been able to, again, leverage these authoritative data sources and visualize them, and then use those data sources for decision making, not just for us though, but also for state health officials who are looking to make those decisions. So again, we only see the slide. I can share my screen if that's easier, but Claudia, I don't want to ruin anything on your end. So if you are able to click out and show that window, that would be great.
Okay, I see the PowerPoint, but yeah, maybe you can share the other window, your browser screen.
Priyanka, are you able to do that?
Am I able to click out of your screen? No, I don't think so.
Yeah, I think you need to
Let me see. I could try.
You could request remote control, Priyanka, at the top there.
Yep,
View option.
Yep, I'm doing that. And trying to click out of the PowerPoint, but it won't let me quite do that for whatever reason. Would it be possible for me to share my screen?
You know, I'm a little concerned right now. I think, you know, why don't we move on and provide the map, you know, at a later time?
Sure, and
the
I
link
do
to
have those
everyone?
slides. No, perfectly fair. I do have those slides that we could just show that have screenshots, but we do have the map. Would love to be able to share that with folks, and if folks have additional questions. So if we could go back to my presentation, I can just go over, you know, very briefly in the next minute, those screenshots. Technology, beautiful until it doesn't work.
Yeah.
All right, slide 21 will start us off really nicely with that. Great, so, you know, this is just a small picture of the tool, but you can kind of zoom in at your leisure as it relates to the actual map, which is hosted on Esri's ArcGIS platform. And so we have a legend here. Basically, the blue buildings are state COVID-19 websites as well as their hotline numbers. So as you're looking at the map, you can actually, there's a search tool, and I was going to show that to folks, but there's a search tool on the top right where you can type in a state, and it'll kind of zoom in right to that state, and you can see all of the data points there. But you'd be able to click on that blue, you know, circle with the building, and then it'll open up a pop-up that will actually have the link to the website and the hotline number there. And we've also drilled down hotline number by whether it should be for individuals or healthcare providers or otherwise. So sometimes states will open up several hotline numbers. In addition, we also have the red dots that show state of emergency declarations. Some of this is issued by governors, some of them issued by state health officials. But if you click on the red dots on the map, it'll also pull up a description of those as well as a link. And then last but not least, elective medical procedures guidance, which really speaks to relaxing some of the medical procedures within a state to allow for that capacity to respond to COVID-19. And essentially, again, that's the yellow shaded in states. And if you click on that, it'll pop up a screen again with a description and a link to more information if that's available. And so those are the three things that we're tracking and displaying right now. Again, this map you know, was just launched this week. So you're our brand new audience that gets to kind of experience this and test it out and see how valuable it is for your own efforts. But we're constantly kind of assessing new layers to add and new ways to display information. And these layers, and this is kind of where I'll wrap up, are directly informed by the priorities that we're hearing from our state health officials, as well as, you know, kind of the landscape of what's going on in terms of how our health officials need to be able to respond. So with that, I will turn it over back to EHI folks.
Thank you, Priyanka. That's very impressive, what the work that you guys are doing. And now we'll turn it over to Lori to share what's happening at the local level and how you're using the power of AI there.
Good afternoon, everybody. I'm so glad to be on today's webinar to dialogue with you all about NACCHO and to talk about the promise that artificial intelligence can bring to local governmental public health leaders, both as they work on the front lines in communities across our country to protect and advance the health of their communities, but especially as it relates to the current COVID-19 crisis. Today, our local health departments and their leadership are truly what we call community health strategists. They have to work collaboratively across environment, policy, and systems level actions that directly affect the social determinants of health and equity. And they must remain primary conveners of other stakeholders in their communities now as well, bringing together diverse sectors such as mayors and county supervisors, educators, housing, labor, fire, EMS, law enforcement, and other key community-based organizations. And it's more critical now than ever that they do this in their communities as we battle this current crisis. So I'm going to spend the next few minutes talking to you about NACCHO, as well as touch on important aspects about how AI is showing promise. So NACCHO is the organization that serves every local health department in the country. And we offer everything that other nonprofits offer in terms of skill building, professional resources and programs, effective local public health practice and systems, capacity building, and technical assistance and that sort of thing. Our organization is made up of the local health departments, but we also include some state public health department members and students, for-profit and nonprofit organizations, and groups like that as well. Our local health departments work to protect and promote the health of the overall community. This is not a health care role typically, although many of our health departments still do some direct clinical care services. But we work directly in the community around tobacco control, emergency preparedness and response, maternal and child health, environmental health, food safety, infectious disease, chronic disease, injury and violence prevention, immunization. But our overall mission is to improve the health of communities by strengthening and advocating for local health departments. Next slide, please. So this is just a background, but a little bit about the landscape of local public health. About 2/3 of local health departments are very small, serving populations of 50,000 or less. However, large health departments, which are mostly urban, although they are small in number, they serve about half of the U.S. population. We consider all important and crucial to the health of our communities. It's also interesting, the governing structure of health departments varies widely across the country. Some are a few states, a handful of states oversee all the health departments in their states. Majority of local health departments, however, are under their own home rule, we call it. And then there are others that are somewhere in between, between the state and local home rule. Next slide, please. So these are just some of the areas where there is either current work going on or there's potential or promise for AI at the local health department level. In terms of Lyme disease, using 17 years of available data, researchers built an AI model that can help identify regions of the country where Lyme disease cases go unreported, and this model can allow states and counties and localities, jurisdictions to develop more comprehensive Lyme disease prevention and control plans. In the opioid area, an Indiana-based company called HC1.com, which is a cloud-based customer relationship management software company for the healthcare industry, created an opioid dashboard. Indiana was seeing a lot of opioid deaths, and the platform integrates machine learning with stated goal of detecting patterns of misuse and abuse among individuals who use opioids. The dashboard organized and analyzed billions of anonymous lab results from diagnostic labs, government testing databases, employers and providers to identify drug positivity rates down to the zip code level. And this allowed officials to implement programs where they're needed most and to identify hotspots of abuse early on, and also to measure impact of programs aimed at prevention and treatment. AI can be used to create risk scores based on lab testing, biometric data, claims data, patient-generated health data, and the social determinants of health that can give providers insight into which individuals might benefit from enhanced services or wellness activities or targeted messaging. In the area of suicide and self-harm, there's been work done early identification of individuals who are likely to cause harm to themselves and ensure these patients receive mental health care to avoid serious events, including suicide. Electronic health records is a treasure trove of data to support suicide risk detection, and using a predictive algorithm, suicide attempts and successes were 200 times more likely among the top 1% of patients flagged, and these predictors of self-harm can allow mental health services to be targeted to these groups to prevent suicide and other harm attempts. Underutilization, in addition to helping organizations get ahead of no-shows in clinical care environments, predictive analytics can give providers a heads up when a clinic is about to get really busy. And since these public health clinics often work without fixed schedules and the staffing is challenged as well, this allows the staffing levels to be varied to account for fluctuations in patient flow and keep waiting times low for patients that are in the office, and limit exposures to patients who are sick to patients who are well as also. And then in community engagement, consumer relationship management has always been a vital skill as we seek ways to promote wellness. We can predict patient behaviors by developing algorithms, again, that look at how patients behave in certain ways, and then we can create meaningful care plans and keep patients engaged with their clinicians and help those patients who are really going to be receptive to changing something in their lifestyle, such as nutrition or exercise. We can use these to inform care management decisions and develop stronger relationships too with patients and providers also. And then just to wrap up here, in food safety, there's promising AI being developed that may at some point allow consumers and or grocers to have a handheld device that determines if a food is free of contaminants, bacteria, or other harms that can create a foodborne illness outbreak. Next slide, please. In terms of COVID-19, the role of public health departments is significant on the ground. They perform general education, community information, provide community information, answering questions, translating information into languages spoken in the communities, and addressing the worried well. They provide education to providers, what symptoms to look for, how to report if there's a suspected case. They work to combat stigma. They work with special populations at risk, including homeless, elderly, poor, underserved, or general at risk. They have been prepared for something like this for a long time with their all hazards preparedness plans. They're activating those to full response levels in their communities right now. And they are maintaining key public health infrastructure and services while all hands are on deck for COVID-19. And they have to continue to do the regular work of flu vaccinations, immunizations, water inspections, restaurant inspections, you name it, they do it. They are also involved in researching quarantine facilities and contracting possible quarantine and isolation activities, locations. One of their key roles is surveillance and contract tracing, monitoring people under investigation and people under self-isolation and facilitating those folks into testing, working with the CDC to monitor incoming passengers or incoming community members. And a key component, as I mentioned before, is conducting community meetings with broad stakeholders to ensure that everybody's on the same page around guidance coming out of CDC, HHS, all of FEMA, all of the federal agencies. The local health departments do that. Next slide, please. This is just I'm not going to go too much into this slide, but these are other opportunities that we see for artificial intelligence at the local level with patients and families, and health monitoring, risk assessment, disease prevention management, rehab and medical management, and for public health officers and their staff, specifically identification of individuals at risk general population health. And as we look to what we can do to address COVID-19 with artificial intelligence, well, this is more technology, but telehealth is growing exponentially to help unburden hospitals and direct service providers by triaging assessment through phone, text, and video chat to limit spread in waiting rooms. There is the use of smart thermometers and aggregated user data to predict hotspots for COVID-19 outbreaks. This was also done in 2018 with our flu outbreak. And this has additional potential to marry up with other data sets to then target exactly where this is going to happen in the community. In the surveillance realm, using hospital data to target at-risk individuals with comorbidities for heightened surveillance. There's the use of Fitbits and apps that can be used to monitor heart rate and sleep duration that might be indicators of potential infection. And I'm going to sort of move on because I think I'm running out of time here. Just on the promising front, we see that the White House Office of Science and Technology issued a call to action in mid-March for experts to build artificial intelligence tools that can be applied to COVID-19 data sets. So that was a great move on the part of our government to help set the stage for that. And NACCHO is part of the All of Us research program, which is a precision medicine initiative that is based on creating a research community of 1 million people who will share their unique health data. And then that information gathered from participants can be stored in a database so that approved researchers can explore factors like environment and lifestyle and genes that can impact health. And then in the budget this year, $50 million was allocated for first year to support modernization of public health data surveillance and analytics at the CDC and state health departments. And we advocated for this to help us fix some of the infrastructural needs in our governmental public health system. So I will stop there. I know it was a lot, but thanks for the opportunity to speak with you today, and I'm happy to take any of your questions on the chat.
Lori, thank you. That was a great presentation. It's fantastic what you're doing, and we're grateful. There aren't enough, obviously, from that map, enough local health departments. So I'll turn it over to Dr. Showalter now, and Dr. Showalter, please share with us what specifically Javion is doing with AI and to address the COVID crisis.
Sure, thank you, Dr. Fraunfelder, and thank you, Lori and Priyanka, for the review of what you guys are able to do, and we definitely need all of your guys's help and services to combat what's going on with COVID-19. We're really excited to talk about what we're actually have been able to do with Javion. Again, as Dr. Fraunfelder said earlier, we've been in a unique position dealing with this healthcare data for 10 years. We've done a lot of work in understanding how social determinants of health contribute to utilization, ER utilization, and an awful lot of work in the inpatient ambulatory area around mortality, sepsis, and hospital-acquired conditions. So we very quickly were able to take our core AI and target it towards COVID-19. Some assumptions in our approach, we assumed there was a high rate of exposure. So there are a number of predictions looking at, whether or not, there's going to be a surge, when the surge is going to be, how bad it's going to be. We assumed from our analysis that there was going to be a high rate of exposure, that data was going to be challenging, there were going to be testing and challenges, that the state reporting was going to be inconsistent. So we focused on the bad outcomes. So what's going to happen with regard to COVID-19 with respiratory complications and organ damage and unfortunately death. And we wanted to predict at 2 levels. The first was a community level to be able to help at the national and the county level. And then as well for our clients at the individual level, looking at focusing on prevention and focusing on treatment, ultimately. You know, as an internal medicine physician, this is the first time that I have faced a, you know, truly widespread communicable disease that's untreatable. You know, so prevention is absolutely imperative because the disease is going to follow its course once we have it. We're still waiting for treatments and vaccines. So, you know, our approach really has been to start with primary prevention and go from there. Next slide, please. We worked on a community level map that gets down to the block group based on the no need to understand social economic risk factors. In H1N1, the disparities led to 3 times the mortality and increased susceptibility to the disease as well. Next slide. We are, you know, again, looking at this as being very proactive. We want to, you know, have the ability for community leaders to connect with vulnerable populations and deliver preventative approaches. Next slide. So this is what's available. So we took all of our knowledge and of using the core AI at Javion towards social economic determinants of care. We're able to look across the 30 million patients that are in our machine and understand how the social economic factors connected with the outcomes for communicable diseases, respiratory illnesses with regard to hospitalization and death. We then used as inputs all of the census tract EPA HUD data that was available at a census level and rolled it up in partnership with Microsoft into a map that you can drill down to the block level. So important thing on this map is we have normalized everything to the state, so you can't really compare California to New York as far as the gradation from low to high. This is the low to high within the state. But if you drill down into a city or a county, next slide, you are able to see the block groups that are at highest risk. So if you are part of the state health department, or if you are a nonprofit or something like, you know, a large food bank from someplace like Atlanta, you are able to prioritize those block groups that are most in need and begin to make sure that you have plans, that you have you know, the resources lined up for them. Then you can drill down into the city level and get into, you know, the details of what's going on at the block group level. Next slide. And once you're at the block group level, we are also providing, you know, some points of interest. So where the hospitals are, where other healthcare pharmacies, clinics are, transportation resources, then food, markets, and restaurants. So that you can do detailed resource planning if you're on a local community level. You know, as we were doing this analysis, you know, we were very aware of needing to make sure that we addressed the vulnerable populations. So next slide. You know, we wanted to validate that we understood things correctly. So, you know, prisons are definitely a high risk area, especially San Quentin, that's currently overcrowded. I think the current stats out there, there are like 3,700 inmates in a prison designed for 3,000. Rikers Island has 10,000 inmates. You know, clearly high risk for, you know, rapid spread and poor outcomes in the prison population. But also all prisons are not equal. So if you look at the U.S. Penitentiary in Lewisburg, you know, it's 1,000 acres. There's 1,500 inmates, and like 600 of them actually live outside the prison wall in a camp. So that is a much different environment than Rikers Islands or San Quentin. So it's still at elevated risk, but it's not at the extremely high risk. So we were able to discern, you know, not only the risk that's known to be for prisoners, but also able to discriminate the risk between prisons as well. You know, another group that is at risk is the homeless. Next slide. So if you look at our map from the county view, you'll see that LA County is low vulnerability. Again, right now it's an epicenter. It's a high area of infection right now. Our map is looking at the baseline social vulnerability. So overall, LA County has a lower vulnerability than some other counties in California with regard to its affluence and its access to healthcare. But there are definitely areas where there is extremely high homeless population. So if you dig into Central City East, that's known to be an area of a high population of homeless, you'll see that that area is actually at extremely high risk. So our technique and our approach is also able to identify areas of homelessness that are at risk. Another area of concern is rural areas, and you can see that we are discriminating. Some rural areas are at lower risk, but then some are at, again, extremely high risk. So this is an area southeast of Atlanta that's rural, that has an extremely high risk profile to it due to, low market labor engagement, highly impoverished area, lesser access to services. So, our plan and hope is that people are able to use that map and advance their community planning. We also, after completing that work, have been working with our clients on patient-specific risk. So this is generating a ranked list of the patients most likely to do poorly if they contract COVID-19. So essentially, it is a rank-ordered list of here is the highest patient that you see with regard to poor outcomes. Here's the lowest. Really focusing again on that prevention. So next slide. We're working with our clients to provide them the identifiers, the names, the contact information, the addresses for these patients, so that they can reach out to them and they can really help focus them on minimizing contact and really facilitate social distancing. These are the patients that, maybe a grandmother may have lots of grandchildren, probably not best to have them visiting right now, probably really good to strictly social isolate, but they also tend to have chronic diseases and need to make sure that they keep getting their prescriptions, that they're receiving telemedicine services, that they're receiving food, that if they're trying to social distance, that they actually do continue to have good nutrition. All of these resources are free, so the map is publicly available. Please visit it and use it. The patient list we are providing at no cost to all of our existing clients as well, and working with them to understand what information we're providing, how to utilize it. They're having very creative solutions, like using the current ambulatory surgical staff that is not working in the ORs, lining up to make these phone calls, working with our payer provider, or our payer providers and our payer customers to figure out how they can use their call centers to outreach about educating on prevention and do something more targeted for those highest at risk, rather than just kind of a PSA text. Once we're about through a third of our clients delivering that, and are gearing up to hopefully be able to, by mid next week, deliver all of those that we can to our existing clients. And then also partnering with our clients on understanding what's going on with the patient in front of them. So a more near real-time analysis of risk for patients that are currently in the hospital and have already contracted COVID-19. So we're trying to help scale the whole way from national needs to acute needs, but have already completed the work and are delivering the patient list and the map publicly. Next slide. So, for more information about what we're doing, you can reach out to Dr. Fraunfelder or myself. You can also follow us on LinkedIn. We're having lots of updates at Javion on LinkedIn. And I appreciate your time, and it looks like we have a couple of minutes for questions.
That's awesome. Dr. Showalter, thank you. There's obviously, this is just a flavor of what's going on in this space around the country. People are working Dr. Showalter, I've got questions. The first one I'm going to pitch to you, put you on the spot a little bit. On the maps, connect the dots for us. How will that lead to directly saving lives? If AI is in this space and it's bringing value, paint a picture of how it will save lives compared to the previous outbreak where there's a 3x mortality rate in people who had vulnerability.
Sure thing. So, so if you look at Los Angeles County, they have 8,000 block groups, which is a near impossible task in 2 weeks to come up with a plan for every block in an 8,000 block group. So if you are one of the, local public health groups, trying to public health or community groups trying to respond to need in Los Angeles, it's an overwhelming task to figure out where to focus. Using the Javion community vulnerability map, you can drill in and identify those block groups, those communities that are at highest risk, and start your planning there and make sure that you are able to deliver services and tackle the needs of the most at-risk population. Again, a lot of this, going back to H1N1 is about access, about nutrition, about education, and, unlike H1N1, we really don't have treatments for this. So, a lot more education and assistance in that area and helping people socially distance and actually have prevention.
Thank you. Now to Priyanka. I love this. I get to ask the questions. So I've got the fun part now, guys. What's the one thing that you would want AI to be doing for you today in addressing the COVID crisis? If you said, this is what I would really need AI to do, or in fact, it's working for you, say, this is really great, but it's AI and it's either what you need or what you've got. What's that one or even two things?
Yeah, and so this is just kind of based on what I've observed from being in ASTHO's Incident Command Center. I don't know that I could say this is the direct answer of our state health officials, although they may agree. But I think, one thing that AI could do, that I could see potential of it doing, is really being able to better assess what the trends are and what those next emerging topics might be before we get there. And I say that because, there have been waves of this pandemic. It started out not at that level, but there have been waves with this in terms of how we've seen it evolve over time since the first case happened in January. And if there was a way to leverage all of that information and all of that available data, again, ensuring that it's protected, that it's anonymous, de-identified, if there's a way to leverage that to show us what we're going to face and how we need to be better prepared for this, it could begin to demonstrate, well, where are the gaps right now that we could be better prepared for? It could begin to show us, you may need a surge of healthcare workforce here. You may need a surge of, treatment here or there. Or if this increases, this is what your state needs to be prepared for. So I think being able to leverage all of the data that was existing to help us with decision making. And I mean, there's a ton that we're learning now. There's a ton of information that's been generated. So AI can learn from this. Again, AI is only as good as the data that you feed into it. And there's a ton of data and information that's been generated. So ensuring all of the authoritative and validated sources are fed into any new algorithms that are built out so that we are better prepared for the next time.
That is powerful. As a concept, it would be great to see that, where we can surge resources ahead of where the demand is. Yeah, almost battle planning. Thank you, Priyanka. Lori, I'm going to pitch a question to you. Do you have any on-the-ground stories using the power of AI or even analytics in having successes in the local health departments? And first, with the COVID crisis, if you've got anything there, or even with some of the other initiatives that you shared.
Well, for us, there are things happening. I gave some examples of those that are either have occurred with the opioid crisis, using all of that big data to drive tracking of hotspots and in campaigns to prevent overdose or misuse. For COVID-19, the challenge with our local health departments is they're in it, and that's not the time to be innovative always, because their hair is on fire and they're on the ground, dealing with the outbreaks and the hotspots in our own communities. So, to Priyanka's point, we really need to incorporate AI into our preparedness planning, and there are plans in every community across this country. And so, what I'd like to see is us to take a new look at those plans and to think about how we can implement for the next time, using some of what happens this time to help inform how we can better use AI for the next time.
Excellent, thank you. And on that note, I'll turn it back over to our hosts.
Great. Well, thank you. It looks like we've run out of time. We do have a few questions here. I don't know if you guys can stay on for a moment or two longer. Is that possible?
I have to drop off at 3, so if there's any questions for states, then I'm happy to answer that in the next minute.
I can stay on for a little bit longer if that's helpful.
Okay. I don't want to keep you guys then if you've got to jump off, but I think what we'll do is we do have a number of questions. So Claudia, maybe what we can do is send out a number of these resources. I think people are interested in this, as well as the map that Priyanka was going to show, the link to that, and a copy of the slides, Claudia. I think that would be helpful to folks. And I do want to remind folks we do have another webinar coming up on March 31st, so come back with your questions at that webinar as well. And I do want to thank Javion and Priyanka and Lori for their wonderful help today and sharing during this really difficult time. And I appreciate your time. I know it's a really crazy time. So thank you for joining us today. And thanks to everybody on the phone as well. And hopefully we'll see many of you back next week on the 31st. Thank you again for joining us today. Appreciate it.
Thank you, everyone. The map's in the chat box.
Great.
Thank you.
Thank you. All right. Take care. Bye.